In this section, I'm going to go over the commonly tested topics in terms of hypertension in pregnancy. And we're going to start off with a case. So we have a woman who comes in about 30 weeks pregnant with only a minor complaint, and on routine screening is found to have blood pressures which are elevated and protein in her urine. Her liver function tests are normal, and we're asked what's the most likely diagnosis, and given all of the options of hypertensive diseases in pregnancy. Given that she has elevated blood pressures and protein in her urine, her diagnosis is going to be preeclampsia. In terms of the others, chronic hypertension and gestational hypertension do not present with proteinuria. HELP syndrome, we would see elevations in her liver function tests. And eclampsia is preeclampsia with seizures, which she clearly doesn't have. We're going to walk through all the hypertensive diseases of pregnancy and go through the definitions and the subtleties in order to help you differentiate them on the Step 2 exam. We'll start with chronic hypertension, which is defined as a blood pressure greater than 140 over 90 millimeters mercury before 20 weeks gestation. And that 20 weeks gestation is the key there. Treatment for chronic hypertension involves labetalol, nifedipine, or methyldopa. It's important to remember that we treat chronic hypertension a little bit differently in pregnancy. And ACE inhibitors and ARBs can cause fetal malformations, and we should not be using them in pregnancy. Gestational hypertension is defined as a blood pressure greater than 140 over 90 millimeters mercury after 20 weeks gestation. So the only difference between chronic and gestational hypertension is when it develops. Again, gestational hypertensive do not characteristically have protein in their urine. And treatment again involves labetalol, nifedipine, or methyldopa. Typically, you only have to continue treatment during pregnancy since it's a disease of pregnancy and should resolve after delivery. Importantly, 25% of these patients will end up with superimposed preeclampsia or eclampsia by the end of the pregnancy. So here we have the most famous hypertensive disorder of pregnancy in preeclampsia. Preeclampsia is broken down into mild and severe preeclampsia based on a number of different parameters. First, the degree of hypertension, with mild preeclampsia being slightly less than severe preeclampsia. Also, the degree of proteinuria, which can be determined either on dipstick or 24-hour urine, which is the gold standard. Edema is not necessarily a diagnostic criteria for preeclampsia, but can be seen less so in mild and more so in severe preeclamptics. We don't see mental status changes in those who have mild preeclampsia, but can see it in those with severe preeclampsia. In addition, vision changes are more commonly seen in those who have severe preeclampsia. And impaired liver function tests, or HELP syndrome, can be seen in those with severe preeclampsia. Other indicators of severe disease include oliguria, or less than 500 milliliters in 24 hours, pulmonary edema, or fetal intrauterine growth restriction. There are a number of different risk factors which you may see in a Step 2 STEM question when the answer is steering you towards preeclampsia. Preeclamptics are more commonly nulliparous or haven't had any children before, can be seen in those who have multiple gestations, or in those who have advanced maternal age, and as we mentioned, those who have chronic hypertension or underlying gestational hypertension, those with renal disease, and of course those who have a history of preeclampsia. This algorithm reviews how you're going to treat a patient who presents on the Step 2 exam depending on whether they have mild or severe disease and whether they're at term or preterm. So first, if they have mild disease, so mild range blood pressures and 1 to 2 plus proteinuria on urine dipstick or greater than 300 milligrams on 24-hour urine, if they're at term, you go ahead and induce delivery. If they're preterm, you'll admit them for betamethasone for lung maturity and magnesium sulfate for seizure prophylaxis in order to prevent eclampsia. If the patient has severe range blood pressures or severe proteinuria, or 3 to 4 plus on dipstick, or greater than 5 grams on 24-hour urine, you'd again admit them, give them magnesium sulfate in order to prevent eclampsia, acutely control their blood pressures with hydralazine in order to keep them out of stroke range, and then make a decision about delivery based on preterm or term, similar to before. Despite all that we know about preeclampsia, we don't truly know what causes it, and the only definitive treatment for preeclampsia is delivery. On the extreme end of the spectrum of preeclampsia is eclampsia, which is tonic-clonic seizures occurring in a patient with preeclampsia. Most cases of eclampsia are going to occur within 24 hours of delivery, with only 3% of cases occurring 2 to 10 days postpartum. Treatment involves stabilizing the mother and seizure control, most commonly with magnesium sulfate. Treatment involves 4 to 6 grams of magnesium sulfate IV with a slow push. An alternative is a diazepam. We have to control the blood pressure with IV hydralazine or labetalol in order to keep the mother out of stroke range, and then ultimately deliver the baby when the mom and baby have been stabilized. We will wrap up with HELP syndrome. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets, and this is how the diagnosis is made. So you can see elevated AST or ALT, low platelets, and hemolysis as indicated by a low hematocrit. Treatment of this is going to be the same as patients with severe preeclampsia. Again, you want to stabilize the mother, control the blood pressure with agents such as hydralazine or labetalol, and deliver the baby.